how we're practicing medicine right now is not necessarily a medical model. It's an insurance model, and by design. So
how do you feel about insurance, Dad? We need the bell. Ding, ding, ding. No.
So I'll probably say it again many times, is we don't want insurance to control your health care.
When you were treating patients, say, in your fellowship and right outside your fellowship in the 90s and maybe even early 2000s, what were you injecting? What kind of injectate? Was it all steroid? Was it something else? Tell me a little bit about that kind of stuff.
When I did arena football, when we did Phoenix Suns, when I did the Coyotes, the NHL, everything's filmed, television. So you're being watched out there. You're being videoed. And so that could be used in terms of making sure we're doing it the correct way. What are the guidelines for that? There's always politics in anything, business, medicine, finance.
Yeah.
I think our philosophy too is one that has a more holistic approach. And indeed with what we do with sports medicine, the body's innate capability of healing itself.
Did you guys know that steroids could be bad for you back then?
If you reverse back 20 or 30 years, especially during some of the professional sports, especially NFL football, now you hear stories about athletes that were getting steroid injections before every game type thing.
Yeah.
And excessive use of steroids, it deteriorates the joint. Ultimately, it turns off your immune system in the joint. So there's your pain reliever. Yeah. I don't care, and I don't want this to sound bad. I don't care about things, whether they're covered or not. A lot of times things are covered, but they're 1980s treatments.
Yeah.
The system is, again, I'm not so sure. I used to think it was broken. Now I think there is a certain design with that, and it's the insurance, or it's a financial model. So we've got to break free of that.
What's crazy is that I feel like in this age of communication, we have cell phones, we have text, we have instant message, we have whatever, we have any message system like that. We can get on our phones and look at another person through FaceTime, Skype, all these meetings, online things. And we don't do it. Welcome to the Pain to Progress podcast, where we help you overcome pain, restore function, and get back to doing what you love without unnecessary surgery. My name is Dr. Tom Sellers, a sports medicine physician, and I believe in the body's innate ability to heal and the power of taking ownership of your health. Whether you're an athlete, active adult, or just tired of living with pain, this podcast is here to guide you from where you are to where you want to be. This is Pain to Progress. All right. Welcome to the Pain to Progress podcast. This is the first annual. I'm very, very excited. I'm with my dad, Dr. Joel Sellers. I'd like to welcome him to our first podcast ever. He's really just, the list goes on and on about your accomplishments. One of the first sports medicine fellows in Arizona, really a pioneer, really the godfather of sports medicine in the Valley, I would say, and mentor, best friend, but most importantly, my dad, business partner, but most importantly, my dad. So I'd like to welcome Dr. Joel Sellers to the podcast.
Thank you, my son.
Yeah, absolutely.
I'm glad to be here.
Yeah, absolutely. So before we get kind of fully going, obviously I have some questions for you and some things I want to get to, but I wanted to briefly talk. I wrote a little thing about Mom. So she unfortunately recently passed away about a month ago. Obviously, we're deeply saddened. It's been a huge tragedy for the family. And outside of being the best mom, she really has made me a better man and a better doctor. She was deeply involved with volunteering with Saint Vincent de Paul. She served as St. Simon and Jude Conference President, District 6 President, affected change on both the large scale and small scale. The SVDP, or the St. Vincent de Paul slogan, is feed, clothe, house, and heal. She would meet one-on-one with underprivileged and disenfranchised people who needed help. Just like a physician asks questions, diagnoses, and treats patients, she assessed needs, gave them resources, food, and tools that they needed to succeed. She worked hard to bring people happiness, hope, and most of all, she listened. She was an amazing listener. So often in medicine, doctors and medical professionals do not listen to their patients. She taught me how to be a good listener and to see the goodness in people. She taught me how to love. Although she may not have taught me anatomy, procedures, technicalities of medicine, she taught me how to be a better doctor, what it means to see the humanity in a person. It will forever be a paradigm shift for me to see her, for all intents and purposes, treat people and impact their lives in the best way. She's our guardian angel. She's watching over us. Every procedure we do, she's right there with us, helping us. So thank you to Mom.
Thank you, Mom. Lori, 38 years, beautiful woman, beautiful spirit. She's always with us, T.
Absolutely, yeah. She's a part of this
Carry
practice. On. Absolutely. Okay, we're going to do a hard transition after that emotional intro. Sorry to welcome you to the podcast this way, but I'm really excited to talk about a few things today. Not only do I love being your son, your business partner, but I like your stories too. And we know you got some stories, so you can talk. So I'm going to let you go a little bit today. I forgot to bring a little buzzer where we go ding, the time's up for talking. And that's for both ways. You should probably be dinging me pretty soon too. Yeah. So, but you were one of the first sports medicine fellows in Phoenix area. In the Valley of the Sun back in the 80s. Tell me a little bit what that was like, and being one of the first, and then also what did sports medicine kind of look like in that time period? Because the 80s and 90s, obviously things have dramatically changed. So tell me a little bit about how it was back then, who you usually treated, and how things have ultimately changed too.
Well, I even might go back a decade before. When I was in college, I wrestled at University of Arizona. The sports medicine program there was very 50s, 60s, and 70s. It was small rooms, training rooms. The athletes, certainly we were treated very well. But on the other hand, it was very much in its infancy, in my opinion, in terms of sports medicine. There weren't really sports medicine doctors other than orthopedic surgeons. And then there were family docs, internal medicine doctors that took care of the athletes. Yeah. But it was a different mentality, versus the primary care role. And as the 80s hit, we started to realize, 90% of orthopedics is not surgery. So what is the other 90%? Who takes care of those people? Mm-hmm. And it's someone who has asthma or diabetes who's an athlete, someone who has other issues, other issues that the orthopedic surgeon is not about to deal with. And I always joke with my orthopedic surgeon friends, I'm not sure they even know how to use a stethoscope. They're fabulous in the OR, but they need help from the medicine side of that. And we had, back in 86 when I started my fellowship, Phoenix was about 1 million people, I believe. We're now 5 million. It was such a boom town at that time. And a lot of doctors with sports medicine on Friday night lights, with high school football, a lot of doctors just volunteered their time. And so someone were hurt on the field, if they needed help. And unfortunately, during that time, we had a sudden death in Phoenix, in one of the football programs in town. And those doctors scattered after that, because what is the definition of a on-the-field doctor? It was volunteering. It was more of a Good Samaritan role, but that liability, frankly, but also that fear of I'm not sure what I'm doing here on the sideline is something from an emergency standpoint, like I said, in cardiac event or hyperthermia or concussion or a neck injury, quadriplegia type situation. They're just obviously part of the field of sports medicine. And at that time, they were looking for certified sports medicine doctors. I was speaking during that time, during my fellowship at the 3rd annual American Academy of Sports Medicine. And at that time, they just started several years before I started my fellowship. And I was in the first class that basically took the certification exam for national certification for doctors. And so we helped build that program. It was more of an apprenticeship, which is a lot of fun. And I traveled around. I went to different programs around the country. And I also, here in Phoenix, we did the Phoenix Suns. We were taking care of junior colleges, high schools. I wrestled in college, and I was involved with Sun-Kissed Kids and USA Wrestling here. And so I very much immersed myself with that. But it very much came from a grassroots type organic origin. And so it's interesting to see how that's developed until 38, 40 years later. It's kind of crazy. And to see you go through your program, we'll talk about that, I'm sure.
Yeah,
how it's changed, the transition.
And so Talk about, you said, and you did say, not to correct you, but you did say University of Arizona.
Did I?
That was my alma mater.
Slip,
so
yeah.
the
University of Oklahoma
is a far
Boomer
superior
Sooner,
school,
baby.
but
I apologize to my Sooner fans out
so
there.
what's your line that you say that when I die?
I'm sooner born, sooner bred. When I die, I'll be a sooner dead.
That's right. All right. That's right. Well, we, I love OU from you, but
that's where
I'm
all
a
our
U of
money
A guy.
went with our children is University of Arizona.
Absolutely. So that's right.
And in Catholic schools.
That's right. I mean, that's really cool to be growing up in a time and becoming a professional in a time that has a lot of change and is the beginnings of the profession. It's got to be cool to see that beginnings and into the more current. And then obviously now, like there's been many paradigm shifts in terms of how we practice. How much, say, when you were treating patients, say, in your fellowship and right outside your fellowship in the 90s and maybe even early 2000s, what were you doing for patients in terms of, were you doing image guidance, ultrasound guidance injection? What were you injecting? What kind of injectate? Was it all steroid? Was it something else? Were you, what kind of diagnostic imaging did you use? Like tell me a little bit about that kind of stuff.
Well, it's interesting. Again, on the field management, we didn't have cell phones back then. There were pagers, and we had to make sure we had a telephone up in the press box or, up in, there at the high school, and the gates were unlocked to allow emergency personnel, all those things that you can't even fathom when you have 2,000 cell phones available and people are watching you. And the thing was odd, too, is that we were filmed, though. Back then, even during that time, everything was filmed. When I did arena football, when we did Phoenix Suns, when I did the Coyotes, the NHL, everything's filmed, television. So you're being watched out there. If you had to put someone on a backboard, you're being videoed. And so that could be used in terms of making sure we're doing it the correct way. What are the guidelines for that? And there was some conflicting stuff with that. Like, say, the firefighters, the paramedics here in Arizona at that time, part of their instruction was to take the helmet off during an accident, whether it be a motorcyclist, and you carry that into the football program. We were taught to keep the helmet on, strap them down to the backboard and control the head, all those type things. So we were learning from each other during that time, and obviously medicine's constantly changing, but our imaging included X-ray in the office. MRI was frankly fairly new. I was about 10 years old when I started. CAT scans were certainly available, but we had no imaging for musculoskeletal ultrasound. And, our injections were primarily numbing medicine and steroid. Mm-hmm. And, we used it by the palpation technique, or I also call it the blind technique. We just kind of palpated an area and dropped a needle in there, and we think we got it. Now, of course, we use MSK, musculoskeletal ultrasound guidance, for accuracy. Mm-hmm. We have, before Orthobiologics, it was all about two anti-inflammatories. Ibuprofen was Motrin, and naproxen or naproxen was naproxen. They were new drugs. They were exciting because they helped with arthritis. They were pain relievers. And it was all about RICE therapy, rest, ice, compression, elevation. Now that has shifted to, we want to promote inflammation, good inflammation, pro-inflammatory, and that's the purpose of what we're doing now with the Orthobiologics.
Yeah. And that does lead to and create an immunologic cascade to the anti-inflammatory effect, and it's a natural thing, right? And we'll get to that too. But did you guys know that steroids could be bad for you back then?
Well,
Did you know that it affected cartilage or worsened arthritis or things like that? Like, was there or was it kind of like, well, that's what we got, so we have to do it. It's better than, getting cut open, doing surgery. Yeah.
I think if you reverse back 20 or 30 years, especially during some of the professional sports, especially NFL football, now you hear stories about athletes that were getting steroid injections before every game type thing.
Yeah.
And excessive use of steroids, it deteriorates the joint. Ultimately, it turns off your immune system in the joint. So there's your pain reliever. Yeah. But it also it turns it off eventually to the point where it's
kind of like an immunological wasteland almost, like a desert of
it is. You've lost
immunity.
Your fertilization, your
it's bad
hydration,
soil, right?
bad soil. That's a good
and bad soil. I mean, then it's hard for us to modulate that, right? Immunologically speaking, we can't. What are we going to do for that? And obviously, there's severity of disease that makes a huge difference too, right? But in the end of the day, it just was interesting for me because even in my my time of med school, we grew up saying like steroid a little bit more. And like even in the last, say 12 years or so, like that's changed a lot. But for you, I'm sure, I was just wondering if that even was like a thought, or it was like, nope, this is what we got. This is what insurance covers. This is what, this is what the standard of care is. And then did anyone question it at all, or did we kind of just do it? So,
well, there were those that were questioning it, but in the mainstream, it was, you evaluated a person for an injury. And, I have all sizes and shapes and age groups of athletes. I mean, I have people that are my age, we're baby boomers, and obviously we want to play like we're 40, but we're trying to stave off surgery and things of that nature. Our goals are different. But even back then where, you had non-steroid anti-inflammatories, you had steroid anti-inflammatories, you had physical therapy, injections, and then pretty much surgery. And the arthroscope was very new. It was about 10 years old. And it originally came out as being a diagnostic tool, kind of like an MRI scan was diagnostic. It's a still image,
visualization,
but you could look and visualize that in there. If you saw pathology, you'd pull the scope out and you'd open up the joint and do your surgery. Mm-hmm. And then eventually that evolved into interventional arthroscopy, where you could use tools and make smaller incisions. And now we're even going beyond that with some of the the orthobiologics. They're using, a lot of surgeons now are starting to introduce that intraoperatively after they've fixed the ACL or a rotator cuff, and they're putting PRP directly into that.
You want a good healing environment after that.
Absolutely.
And you want to talk about an inflammatory response that we're going to have for cutting open.
Very safe.
For doing that. You need to you want to have a better immunological response after that, not like a haywire over response to that, some of that tissue disruption and the cuts, right, and the surgery. So, I mean, that's really cool. So I'm a DO, you're a DO. So I'm a second generation doctor of osteopathy DO, and that's a medical doctor, but just a different schooling, different type of school. I know that your claim to fame was you treated Odysseus, right? After the Battle of Troy?
After, the Odyssey.
Oh, okay. All right. No, I'm just kidding. The
not the Iliad. I think I said Ilium.
The Ilium. So DOs, hundreds of years, but newer to the scene than some of the other ones. Tell me a little bit about what it was like practicing as a DO in the 80s, 90s. How has it changed from that perspective? Because for me, we want to talk about kind of ostracized, that kind of thing, maybe a little bit prejudice, if that's not the right word, but some sort of kind of not feeling like lesser than. I didn't really feel that too much, right? Like they I think that most MDs and most other institutions kind of saw DOs as a very similar thing, a very even playing field with the other doctors. And I'm sure there's some subspecialties and specialties and residencies that weren't that way when I was training. But at the same time, I feel like it's changed a lot from your generation to my generation. Tell me about in your generation when you were 20-something, 30-something, and a young DO, what that was like to practice here and what that landscape looked like.
Well, I came from Oklahoma, wrestled Oklahoma University, and then I went to med school at Oklahoma State University in Tulsa. And at that time, a lot of the hospitals were segregated. They had osteopathic hospitals and they had allopathic hospitals. And many of the allopathic hospitals, MD hospitals, did not allow DOs to train in their facilities. And so it was kind of like the Republicans and Democrats, very politically driven. We're fully licensed physicians in the United States. I believe back in that day, we perhaps were 10% of the population of physicians. Now I think it's more like 25%. But it's interesting because I think we worked harder, because we really had people come after us when we were doing the professional teams here.
Hill to climb.
Oh, absolutely. And we had other groups that were after us because we were taking care of professional teams. Yeah. So we had very much support from our community here. And frankly, Jerry Colangelo, who was the owner of the Suns at that time, was very, very supportive of our group. Pro-DO. Mm-hmm. And I have friends that are retired now, well into their 80s, but in 1965, the DOs were allowed to be fully licensed physicians in the armed forces. That doesn't seem like that long ago for me. Yeah. I mean,
your lifetime, 100%.
My lifetime. Yeah. And now, I was not allowed to practice in some of the hospitals, including the one that you trained in your residency. Yeah. Mm-hmm. And now those doors have opened. There's a lot of mixed staff. A lot of people, not that they don't pay attention, but they see DO or MD, they're not really paying attention.
As much, I don't think. Yeah.
But we do have an emphasis on, we do all the anatomy, physiology, the same type programs. There's a lot of mixed staff in there. There's DOs and MDs that train people in the med schools and the residency programs. And so I think in some ways it's an advantage as a sports medicine doctor because we have an emphasis on the musculoskeletal system. But there are oncologists, neurosurgeons, plastic surgeons that are DOs that they don't, that's not their emphasis. So in a lot of ways, I mean, there have been a lot of walls that have broken with that. There's always politics in anything, business, medicine, finance, politics. I mean, there's always that entity.
True.
But I'm very excited that I'm an osteopathic physician.
Yeah.
I think our philosophy too is one that has a more holistic approach.
Absolutely.
And indeed with what we do with sports medicine, the body's innate capability of healing itself.
Yeah, that line kind of rings true for me constantly, really, in what I do. And it's funny because I went to osteopathic medical school, and even though I love that you were DO and then I would be a DO, right? And we have very mirrored lives and timelines in a lot of ways. Some of the same stuff, and obviously different generations, of course, but similar institution, similar experiences in many ways, right? And being a DO was exciting because you were a DO, but also I think I took it for granted a little bit, the DO thing when I was in school. So well, this school's kind of close to me, I got in, I'm doing it, but then the more I look back at some of those osteopathic principles, like you said, the body's innate ability to heal itself, that's something I use every day. We're not the things ultimately that we're doing from a non-surgical orthopedic, injection-based regenerative orthobiologic perspective are not really magic wands, but they are really amazing because we are just stimulating the immune system to cause a good, healthy cascade in response. So the body's innate ability to heal itself, that's taking what's good about you and enhancing it, amplifying it, and hopefully pointing you in the right direction. So, a lot of what we do is modulation, is, hey, you're right here, let's tip the scales into this direction so you go on a better path, where most of the times chronic inflammatory states and chronic issues, they're going to tip them back down in the wrong direction each time. But it's kind of cool with us, the Orthobiologics perspective, we're doing a natural way to flip you towards a good long-term anti-inflammatory solution ultimately, but a good microenvironment, immune function, all that kind of stuff. So, I think it's really cool. I think I have more respect of being a DO now, having gone through fellowship training, where I felt like I was way more prepared from a musculoskeletal perspective. And then also, because we're in the world of regen and orthobiologics, I've seen it, right? And you've seen it, right? You've seen some amazing results. You've seen some beautiful things that really, at the end of the day, I'm just harnessing and enhancing what is, you're biologically able to do at baseline, right? But I'm just enhancing that and modifying it slightly. So I think it's really cool, and I'm proud to be a DO too. It's kind of fun.
We had a lot of support from some of my MD friends too. I've got an opportunity to rotate in my fellowship up at the Cleveland Clinic. John Lombardo, he was the team doctor for the Cavaliers. I got to work with him for a month, and
that's cool.
Very pro DO. He was one of the chairman of the U.S. Olympic Medical Committee at one time. And so, they saw the value of that. It's very much, it's not just the doctors, but, we have such fantastic physical therapists in the Valley, athletic trainers, nurses, nurse practitioners, PAs that, it's very much a team thing. It's an exciting time that we didn't have necessarily that back in the 80s. That was another transition type thing now. Yeah, but I know we're going to get involved more with the talk about relationship, and that's the meat of what we do.
Look, you mentioned physical therapists. That's a good example of PTs are so so integral to the success of what we do, because you cannot get there without stepwise strengthening, return to play, return to function, and that's what we're treating in a lot of ways, right? We're saying, hey, there's an issue. Sometimes it's chronic, sometimes it's more acute, subacute, but we have to modulate things, we have to change things, we have to do it the right way. And you alluded to that with image guidance, ultrasound guidance is key. It's a huge part of what we do. But then also, we need to progressive load bearing of the joint, of the tendons around the joint, of dynamic stabilization of the joint. If we can't get that with high quality PT, then our outcomes are just not going to be as good. So, I mean, it's definitely, it probably always has been a multidisciplinary approach, sports medicine, but I feel like more than ever, it's so important and so vitally important for outcomes.
Absolutely. Yeah.
And what's crazy is that I feel like in this age of communication, where you said you didn't have cell phones before, that you had a landline or something, an emergency phone or something, on the sideline. We have cell phones, we have text, we have, instant messaging, we have whatever, we have any message system like that. We can get on our phones and look at another person through FaceTime, Skype, all these meetings, online things, and we don't do it. I see more than ever poor communication between specialties. I see more than ever just go to physical therapy, kick them out, go to PT, do something. I don't know what they do. They do some.
But they
stuff.
can figure it out.
They'll figure it out. If I don't really know, hey, you have knee pain, but PT will figure it out. Well, PTs are amazing. Sometimes they do figure it out and they do help you, and they do, and a huge percentage. But also, like, you need people that care, that are going to have that communication line in between multidisciplinary providers and specialists. So I feel like we've lost that way. I don't know why. But we don't talk to people at all. We just, and I don't know what that even is, but I feel like that's a huge talking point for me with patients, is that communication is key. And like when you see me or when you see you, we're going to communicate with your provider, your primary care. You're going to communicate with your orthopedic surgeon that might have sent you here from this issue, right? Because you're not a surgical candidate or you need to do this before surgery or whatever it is, right? And then your PT. Right? Like we need to be involved stepwise in the relationship of that. Because for me, we do a lot of injection-based therapies here, but it doesn't stop on the day of injection.
Right.
That's the beginning. That's step one. I mean, I guess you could say step one would be like us doing a diagnostic scan, workup, history taking, all that good stuff. But really, step one is the injection, right? Step one is the procedural aspect of what we do, but that's only the very beginning. Right, that's the beginning of the healing process, and so
I think that's you're on a great point, because the old way was, and again, part of that, it's not a medical model, and today's medicine is how we're practicing medicine right now is not necessarily a medical model; it's an insurance model, and by design. So,
how do you feel about insurance, Ted? We need the bell. Ding, ding, ding. Right. No. 10 minutes past.
The rubber band, the anger management.
I'm falling asleep.
But, it's relationship building. It also is, we front load that by performing certain things at the beginning, not, okay, you got to go to therapy for 3 months and fail that, then we can get an MRI, then you have to go to the surgeon.
You have to get an x-ray when it's
Yes,
not,
and 6 months later, you're finally getting your treatment. We have the patient come in, we can do an evaluation that day, we can do an ultrasound that day, and we can come up with a game plan before they check out.
Yeah, same day game plan.
And I've always said this, I'll probably say it again many times, is we don't want insurance to control your health care. I don't want insurance to control my medical care, and absolutely not about to have insurance control your health care.
No.
And that's where people, I think, as amazing as it sounds to them, it's like we're very much about relationship building. Imagine that. You get to see me as a physician or a younger, more handsome version of me. That's your choice. You're not going to be in a mill. You're not going to be switched around and be seeing someone. And there's your timer, having a 7-minute timer to be able to address some of your questions and move on to the next patient. This is not a mill. And again, I've seen models. I've worked through different models, and some of them I'm just not going to work in anymore.
It's quantity over quality,
yes,
right? Like it's just like, hey, next, like, in line conveyor belt style medicine, because, and it's not even the physician's fault, because they're good docs. There's a ton of good docs, good training, good docs. But they can't,
they're underutilized.
The only way that they can make it is just by increasing amount of patients being seen. Like there's no other way that they can figure it out, right? And so they do what's easiest, and that's like, I'll just see more patients. But that's at the detriment to the patient, because these are individuals.
Burnout.
And, burnout, of course, too. But like that,
work nights and weekends. Then
Yeah, that's
Those
a good
days are
example.
over.
Yeah. Just keep working harder and harder and harder, and eventually you'll really break through. No, and by the way, reimbursement rates, have they been going up every time? I don't think so. No. But that's not in the scope of this practice. And I'm already gonna ring the bell, bing bing, or this podcast. I'm gonna ring the bell because we could talk about how bad insurance is for a long time. Yeah, but it can be really truly terrible. So I agree with you there. You don't need to sell me on that. Yeah. But tell me about, so I like to call it the middle path. Sometimes I call it the gap, but there's a conservative management. So say you have somebody with knee pain, shoulder pain, some sort of musculoskeletal complaint. There's a conservative side of physical therapy, rest, ice, compression, elevation, the things that you were saying. There's also the surgery, ultra aggressive surgical approach, like, hey, let's cut, let's mash, let's
totally replace.
Titanium. Let's like put metal in there. Let's do just completely, reset the whole everything, right? But in the middle, there's this swath of land that's really kind of amazing, I think, that can be an aggressive approach compared to the conservative, but no surgery involves. And that's kind of the area that we inhabit. We inhabit this middle ground, this middle path that I love, between the very conservative and kind of over-the-counter, so to speak, therapies, and then the ultra aggressive nuclear options, right? And that's where we inhabit, right? Like, you want to do this is a Red Ryder BB gun on this side, and this is a nuclear bomb on this side, and we got the nice we got like a RPG, right? Like, we got something good, right? But we don't have that the
carpet bombing versus selective smart,
because I hate that people don't know that there's options, right? So that's one of my goals, and I want to bring, and this is a huge part of what the podcast is about. Is I need to bring awareness to the fact that people have other options than just live with it and just surgery. Let's just replace everything, and you're no longer you're a titanium in terms of a knee, right, or something, a joint, right? And so, tell me about how you think we inhabit that middle path, and what we do a little bit, particularly with platelet-rich plasma, and then also microfragmented adipose tissue, or MFAT. Can you talk a little bit about that?
Well, again, we're again, from a sports medicine standpoint, I'm no longer on the field management. I mean, those nights and weekends are precious to me now, so it's nice in terms of in office. We tell, and a lot of times when I have patients that come in, we have patients that come in probably within one visit. Maybe it requires a little more workup. I can usually tell whether someone is a surgical candidate or not. And a lot of people come in, they're nervous or anxious. That whole, gosh, am I going to have surgery? And, is my knee worn out? Is my shoulder, my hip? And it's stressful for them. And if we can just calm that anxiety down and say, no, this is not surgical management, in my opinion.
Don't you love that?
I love it, because
it's so fun to say,
thank you so much.
Hey, you're good.
And are you willing to try other therapies? I don't care, and I don't want this to sound bad. I don't care about things whether they're covered or not. A lot of times things are covered, but they're 1980s treatments. Yeah. And steroids just are covered, or
at the detriment of the tendon of the joint.
They're the orthopedic surgeons are feeling that pain too. They're getting reimbursed at such a low rate, and the enormous amount of responsibility for orthopedic surgeons during a surgery, the risk of infections or something worse, and their postoperative care for that patient. It's just the system is, again, I'm not so sure. I used to think it was broken. Now I think there is a certain design with that, and it's the insurance, or it's a financial model. So we've got to break free of that.
Absolutely.
But you have someone who has an ankle sprain, someone who has a tennis elbow, someone who has a rotator cuff tendinopathy, things like that. Those are not surgical conditions. And yet the orthopedic surgeons are the ones that they're being sent to that, or maybe they are trying this steroid, or maybe they get to a point where, again, it's a learning curve for everyone. They're sending them to us because, this patient is not a surgical candidate. Go see Sellers and Sellers. Yeah. And so that part of it's exciting. We're using the body's, again, innate ability to heal itself. And, what are different products that are very legitimate? Autologous products. That means something that's coming from your body, your blood, especially platelets. That's the first line. They're tiny anucleated. They don't have a nucleus. They're little tiny cells that are in your body that trigger your body's immune system to heal. And, inflammation, I never realized how, it sounds very geeky too, but I love molecular biology and the inflammation and proliferation and the remodeling of tissue. It's uniform if it's a healthy person.
Yeah.
Things can interrupt it, absolutely, but that's what we're trying to accomplish with your body. Is we're trying to use platelet-rich plasma. That's taking blood, your own blood, so it's autologous. Your risk of any kind of reaction is almost zero because we're using you and just
you back into you.
And FDA, the Food and Drug Administration, only allows us to minimally manipulate human tissue. You can't sell your kidney. You can't do this and that. And what we're doing is concentrating your platelets in a high concentration, and we're injecting it into that affected area, whether it be a tendon or a joint. And so what that's doing is it's triggering your body's immune system to start over and try to heal that again. Inflammation, where the body's immune system try to heal that, the messenger cells start to go there and proliferate and heal, and then you have remodeling. So a lot of injuries we see, especially things say like tennis elbow, which, people go, they've been around, they come to us, say, how long have you had your tennis elbow? 2 years. I said, well, have you had any injections? Yes. What were they, steroid? Did they use ultrasound? No. Well, there's your flags for us. We don't use steroid on something that's 9 months or 2 years old because there's no longer really inflammation. It's scar tissue. But we use PRP very frequently. We also do MFAT, microfragmented adipose tissue. We're taking fat, usually from your abdomen, like a form of liposuction in the office. We separate the fat, we concentrate or microfragment it. We break it up into smaller fat particles. 2 ways you get stem cell, fat and bone marrow. That's it. There's a lot of false advertising right now. There's a lot because, it's a difficult area in terms of control. The FDA considers PRP, platelet-rich plasma, and MFAT, microfragmented adipose tissue. They consider those to be FDA compliant, meaning it appears to be safe. But it's not a food, it's not a drug. So they're learning. They have a new category for the biologics, and it's a huge field right now. Whether it be in immunology, from cancer therapies to the orthopedic world, or neurological conditions such as Parkinson and degenerative neurological diseases. And so that's why it's exciting for us, and we're getting great outcomes. And that gets you pumped up like, hey, we're onto something here. We're making a difference. And so, but the fun part of it, you roll that into working with my son, working with great staff, and having relationships with people. And some of these people I have known since the last millennia, and my patients included that have seen me, since Ronald Reagan was president, so it's still fun to practice.
Absolutely.
Yeah,
that's great. I think, and just to go off of what you were talking about, especially with PRP, platelet-rich plasma, we use that quite often in complete lieu of steroid, right? Like every time, because what we see based on the literature, and again, FDA compliance, great. Do they approve it? It's not FDA approved technically. I think there's some definite reasons that could be, right? One of which is that it doesn't fit, and this is a little bit, conspiracy-ish, I guess, but, how do they patent it? How do they package it? How do they make money off it? It's a relationship exchange. It's between the patient and the doctor. It's a process. It's a spin process. Yes, we concentrate. We go from whole blood to plasma to platelet-rich plasma. Yes, of course, but it's just that. It's a patient-doctor relationship. There's no imaging center that they need. There's no trademark on it in terms of like it's all between you and another patient. And so I think it's hard for them to package it, put a bow on it, make a little logo on it, and then sell it, right? And so. But yes, you said it's FDA compliant, so that's great. But what we see in the literature with platelet-rich plasma especially, and with microfragmented adipose tissue from that matter, is that we see, platelets arrive first on the scene. We see a big pro-inflammatory spike, but then we see a long-term anti-inflammatory effect that's natural. And we ride that wave. And what we see in the literature, more than just like, hey, this is going to heal everything perfectly like osteoarthritis is a tall task to say, like, it's just going to erase the arthritis, right? Like, that's really not what we say. But the literature really supports the good studies that do high concentration PRP, billions of platelets, 8 to 15 billion platelets, that kind of stuff, good high quality platelet-rich plasma, that we see two things happen. We see decreased pain scores and we see increased functional scores. WOMAC, all that kind of, whatever questionnaire you're using, we see decreased pain and increased function. And I say to patients, like, what are your goals, right? What are your goals? And most of the time they align directly with pain and function, right?
Absolutely.
Pain and function is the name of the game, right? Because most people don't say, well, I have a partial articular-sided supraspinatus tear with the subdeltoid bursopathy, a little bit of AC joint arthropathy, glenohumeral arthropathy. No, they don't really care. I mean, they do, right? And it's my job to teach, right? We say, hey, on the ultrasound, this is all on the ultrasound. Look at this layer, this is where you have a tear.
You could show them in the room.
I think that's amazing, right? But more than that, they want to get back to what they do before. They want to get back to what they love. They want to get back to holding their grandkids, picking up their grandkids, playing, sports, high level sports, pickleball, and high level sports, young athletes, old athletes. They want to get back to what they love, and that's where the functional aspect is. And you can't get there with the pain, right? If you don't have good pain scores, if you have bad pain like scores, like high pain scores, you're not going to be able to do what you love, right? And so to use it like that as a completely, of a total paradigm shift for steroid, right? Like we're saying, hey, steroid in some ways does do that, right? It does decrease pain and increase function on a very short time period and window at the detriment of the patient's collagen, the patient's tendon health, cartilage health, joint health, and potentially some systemic health as well, right? There's some systemic risk
with
factors.
Diabetics, with peripheral vascular
Totally,
disease,
yeah. So for me, like you're saying that we get that decreased pain, increased function when done correctly, when the studies support that. Then you're saying that we ride that wave for long periods of time, or a year plus, and then you're saying not only would you get a long-term anti-inflammatory effect that causes you to be in better, less pain or no pain with higher functionality and functional capacity, but then we're saying, hey, now we're strengthening with PT. PT is so important. Now we're saying let's progressive load bear. Now we're stabilizing.
And you can strengthen.
And then you can strengthen. Your pain's in a better zone to get more out of PT, to get more from your physical therapist, to get more out of your sport, right? So now we have a recipe for like absolute success and longevity, because ultimately we're in the business of preservation as well, right? Like people want to preserve themselves as best they can, because that's part about being human, right? Is to be able to do the things you love, right? And so those pain points for patients I see all the time, right? And I love that we're doing something that gets them back in the fray, gets them back to play, right? And so, gosh, I can't say enough about that. And it's been some of my most exciting cases are those, right? That it's like, hey, I couldn't do this, now I can, right? And everything's a bell curve in terms of success, but we've just been having tremendous success with patients. And look, even if the severity of disease is at the highest level or higher level, most people say we get them 50% better. Well, what would that unlock to your life, right? Mm-hmm. What would 50% better unlock if it's god awful, if it's the worst thing? My knee is constantly aching. I can't even walk the dog. I can't even get up from the couch. I can't even sit on the toilet, right? But if we get you 50% better, even with severe arthritis, I mean, think about that. If that unlocks those things, right? Are you going to be running marathons? Maybe not, right? No. So goal setting is important, but I just feel like it's been really fruitful and very I've just been loving that we actually get to impact people's lives and what they love. So I think it's pretty cool.
Well, we love collaborating with people. We our team approach here, especially you and I, because we take the time and when that patient comes in for an orthobiologics procedure, they get both doctors. We're both in there. We have no other patients in the office during that time. We focus exactly on that patient. Yeah. So it's very much a 2-on-1 care and communication vital. And again, that relationship is probably one of the things after 38 years of practice that I think is so precious to me, especially this last year with your mother or my wife going through that with such support from our community, from our church, but also from our patients here. It's just amazing, how beautiful that is for us. And again, we're so appreciative of that.
Yeah, we're blessed to have the patients we have, that's for sure. And some of that is, most of that is how you've treated them throughout your career. And that's a testament to you, because you're saying Ronald Reagan era patients, right? And so like that's a while ago, right? That's not a 10 years ago.
I'm still getting
right?
some young ones now too.
Yeah,
so
that's right.
Good.
That's right.
And now,
but that's a testament to you and the care you give to your patients, and the care you give to your patients is reciprocated, right? And so they care for you. So I think that was testament to like what happened recently is like, we did get a lot, like we said, hey, in lieu of flowers, like, can you donate to Saint Vincent de Paul if you feel like it in your heart? And then we got lots of donations. Like Saint Vincent de Paul was really excited because like they got, and you call it feed, clothe, heal. I mean, their principles and everything like that, like that's so cool that mom, because it's part of us too, but that mom could have that gift for us even after her like physical presence here is done. So pretty amazing to practice with your dad. Like, did you think that that we were going to practice together? Like when I was like a kid, like a little baby, like you're like, oh, this guy's going to take over the family business, or did you say?
No, I don't think I approached it that way. I mean, my father, wrestling coach, National Wrestling Hall of Fame guy, Oklahoma, and in wrestling. I love sports, and that's probably what. And then when you start getting hurt, and then you go to the doctor, and then you're going, gosh, this is kind of cool too. I think that's the direction I took with that. But I don't know whether I wanted to follow in his footsteps. And he and my mother were very supportive of me, in terms of medicine. And I know that for you growing up, you had such an imagination. You were so well-rounded. Loved music, loved sports, loved dinosaurs, loved and ultimately, start taking you to some of the games, and you'd travel with me.
Yeah.
And that was very fun. But to get the teenage years, and you were saying, Dad, I'm not going to be a doctor. I go, okay, that's cool. I think trying to push a few buttons there. But then you get into college and thinking, I think I want to do pre-med. I'm going, okay, that's great. But it was never like, oh, wow, we can practice.
Yeah.
I think I didn't want to spoil it either, because I didn't want it, it's the, not reverse psychology.
Don't do that.
Don't do that, and you're going to do it. That's typical. So, but especially I found it fun, and it had nothing to do with me, but other than when you were in med school and you could not rotate with me, because a lot of your friends were able to rotate me as a physician, as a trainer. You couldn't rotate with me because we're family, and you can't grade family, in medical school.
You could have given me a C. I didn't care.
Yeah. So, but I remember you going to a sports medicine colleague of mine, and you call me, and I go, Dad, I can't believe I saw this cool thing. I go, Thomas, I do that, and so I think it was an opener for you. And doing
he
family
did it
medicine
really well though, Dad.
Yeah,
no, I was kidding.
he is very good.
Well.
Yeah, sweet.
It's good.
So, but again, the fact that you came back and said, I want to do sports medicine now, and I remember when you were applying for a fellowship and said, I don't want your help with this. And believe me, there's but you earned all that on your own. Now again, you've enhanced this practice, especially from the business side. You're now a partner. I'm just very proud of building this with you, and I know that you're just doing such a fun job.
Thanks,
and we're trying to navigate right now through a difficult part of healthcare, but we're also gaining more independence, from insurance, because we played that game. I played that game for so long, and patients now, it's like, oh, this is not covered by insurance. Yeah, it's not, or maybe it is. But then they say, well, I need to make my deductible. I go, you have a $7,000 deductible.
Yeah, that's pretty steep.
And I say, you got to be pretty sick to make that, But I think more and more people now are realizing that it's not bad for things that are not covered. There's a whole new world, and I think in some ways, insurance sometimes can be more expensive than cash-based things.
Yeah, you see that all the time.
But we do great. We're doing great things. We are conservative in a lot of ways, but and we do safe things. But we also want to do no harm. That's our first rule in medicine, is to do no harm.
Don't you think that the image and like if we were, when we started this venture, it's now been like 3+ years, right? It was into the 4th year, pretty much.
Yeah,
that
right now, right?
And for us to start this venture together, like I feel like the picture is becoming clearer too. Like is it exactly? There's
Clarity.
always room for improvement. We're like systems based that we do it in, and that protocols that we're implicated implicating that are helping our patients. We are constantly trying to tweak things in the better direction, right? But I feel like more than ever, like we're really honing our craft even more.
Sure.
I think that the skill set's always been there with the injections, musculoskeletal ultrasound-guided injections. I feel like that's always been there, but like the behind the scenes stuff in terms of getting people in a better zone, there's actually a lot more than you think. From that perspective and the business aspects and everything like that. I just feel like we're building something that's really kind of beautiful. And you say, why do you do this, right? Why do you do medicine? And a huge part of this for me is legacy, right? Like I'm not doing this for the money. I'm not doing this for the clout, the fame. It's for the legacy of us building something with our name on the building, right? It means something to us, right? Yeah. There's many jobs where it's just a job, right? But this means something to me, right? Building something with you means something to me. And I just love helping patients out, helping people out and listening to their story and be able to provide solutions to their pain, to their issues, to their and many times I've seen this a lot. People come in, hey, I saw this doctor. No one could figure out what's wrong. And a lot of times it's not 100% right, but a lot of times we can figure it out because of our skill in musculoskeletal ultrasound. So, and I wanted to talk a little bit about, earlier you said like, hey, it's me and you in there with the procedures, like on some of the big procedures that we do, injection-based things, ultrasound-guided injections. We do them all together, right? Every time we block our schedules out, you get 2 doctors for an hour and a half. Like we spend all the time with the patient. There's no other patients in the building, right? Or in our suite. But basically, many times we also have musculoskeletal ultrasonographers. Like Colin is a wizard at ultrasound, and so you're getting a multidisciplinary approach. In there, in the procedural room, we get a DPT trained ultrasonographer there. You get 2 docs that are board certified in family sports and ultrasound trained, and you're going to get potentially even their PTs come in. If a physical therapist refers, we've had PTs come here and observe. So they're seeing the beginning of their journey there too. Like, what do we do? What do we attack in terms of injection, like locations? What's the pathology? This just helps so much. And it's been so fun to collaborate with those people.
Absolutely, yeah.
And learn from them because, gosh, I've learned so much from the PTs I've talked to. I've learned so much from people like Colin and the ultrasonographers that we've dealt with. I feel like I've just learned a tremendous amount. So it's really cool to build that kind of too, and that network of healing. I think it's just really cool. So it's fun.
Beautiful, man.
Yeah. So you said earlier, that you just really did not like to work with me at all. No, I'm just kidding. No, you said later in this podcast we're gonna sing a song together, and it's gonna be a little "Take It Easy" by the Eagles. But you talked about blood harmony, and you talked about that because we were kind of pre-gaming in like this podcast, like, hey, what do you want to talk about? Like anything in particular? And you said, I want to talk about blood harmony. Can you talk to us a little bit about what blood harmony means and maybe how we exhibit it?
Well, blood harmony, I know in music, especially in country music, there's always that discussion about blood harmony. It's families, relatives that sing together, sing in harmony, that have like this innate sound that's this beautiful sound that maybe it's a genetic thing, but also it's something that is a connection that possibly they might not have by blood. But it's also, is it unique? I don't know. But I know that I think we make some great things together. I know for years I have been frankly singing lead vocals, and now I'm going to be singing harmony, and I want you to take the lead vocals and run with it. Because number one, you have a beautiful voice musically, but also I think that that harmony of one enhances the lead vocal. And that's what gets me excited about this, that we are building something together, and our relationship is so rich right now. And with you and I, and with our daughter Rachel, and our son-in-law and daughter-in-law, and our grandbabies, it's just beautiful thing through beautiful things, through tragedy, through grief, but also through joy. Yeah. It's just wonderful time, for us in a lot of ways. And life beats you up pretty good, and you just kind of you need that family, you need God family and love, and we got plenty of it, man. So very proud of you.
I mean, I think that for us, like, I do think we have blood harmony. Like we have this kind of synergistic effect of 1 + 1 = 3, that we work just well together, right? And we never fight. No, I'm just kidding.
Not in front of the camera.
And we never bicker.
We can discuss, yeah.
No, we do. No, we do.
That's
but
sure.
But man, like, I just feel like this practice and what it's morphing into, and our care for our patients and our love for them, really is. So it is a love, right? Yeah. Has just been so fun to build on, right? And so, I love blood harmony. We're gonna sing in a little bit here, so I'm excited for that. Yeah. Well, Dad, it's been obviously you've been a pioneer of sports medicine in the Valley, a person, like a friend, mentor, dad. It's been awesome to grow with you, learn from you. I had so much fun having you on today. Obviously, this is our practice, this is us, but obviously I'm going to do some more podcasts with other guests and everything like that. I'm absolutely going to have you back.
Love to be back,
because
man.
It's so fun. Yeah. It's so fun to talk to you.
Fun.
And then really this next part, we're going to sing a little song. It's by the Eagles, Take It Easy. I feel like you and I listened to this song a lot growing up, like in your car, windows down, kind of just hanging out. Yeah. I don't know if it has any like extra significance than that for us, but it's just a band that I know you love, and a song that I think I wanted to sing with you. So it's just a fun song. Man. So we're gonna do a little song, just a little bit, off the beaten path. You don't really have a lot of podcasts ending in song, but it's
our family, the singing.
Yeah, we do sing a lot. Absolutely, we sing
spontaneous outbursts.
Yeah, a lot of musicals. Yeah. But anyway, we're gonna do a little song together. So I'm gonna get my guitar out, and we're gonna get it going. But thank you again for being here today.
I know,
man. For everything too, right? Everything that you've helped build in the Valley, and all the everything. So
you enhance our lives, and you and family is wonderful. It's a beautiful thing.
Yeah, absolutely. Love you, Dad.
Love you, Tom.
All right. I'm running down the road trying to loosen my load. Got 7 women on my mind. 4 that wanna hold me, 2 that wanna stone me. 1 says she's a friend of mine. Take it easy, take it easy. Don't let the sound of your own wheels drive you crazy. Lighten up, but you still can. Don't even try to understand. Just find a place to make your stand and take it easy. I'm standing on the corner of Winslow, Arizona. Such a fine sight to see. It's a girl, my lord, in a flatbed Ford, slowing down to take a look at me. Come on, baby, don't say maybe. I gotta know if your sweet love is gonna save me. We may lose or we may win, though we may never be here again. So open up, I'm climbing in. So take it easy.